I did was touch it. Oh, well. Hi, I'm Pamela Jackson. I'd like to thank the organizers for having me speak today. I'm going to talk a little bit about modeling edema and how that might benefit brain tumor patients. So we're a little background. We're interested in mostly glioblastoma, which you've heard about several times during this meeting. It's a highly invasive primary brain tumor. It's resistant to treatment and considered to be uniformly fatal with an overall survival of about 15 months. And magnetic resonance imaging is used to non-invasively visualize this, and it also assists with diagnosis and determining treatment for these tumors as well. And so two main types of imaging that we often use for glioblastoma are T1-GAD. T1-GAD images visualize enhancement due to leaky vasculature. We give an exogenous contrast agent intravenously, and that actually leaks out of the vasculature that is haphazardly formed due to the tumor. And then second, we have T2 weighted images, which also has a hyperintensity which shows up as edema, showing edema, which is basically swelling, and it's at least partly due to this leaky vasculature that's forming as well. And so just to get some terms, I think Lee did a great job earlier talking about some terms we talk about when we look at the imaging and the phenotype of the imaging, can kind of say. And so I'll just kind of skip through this quickly and showing contrast enhancing as well as non-enhancing regions. So contrast enhancing is determined by the T1-GAD, again, for that contrast agent. And then non-enhancing regions are those edematous regions that are outside of the contrast enhancing region. So a little bit about the extracellular space and blood-brain barrier and edema. So in mammalian brains, the extracellular space normally is about 20% of the brain. And so even though you think about it being something really small, because you think about it in 3D and pervading throughout the brain, it actually takes up a decent amount of space. And this is partially maintained by the blood-brain barrier. And so on top, you see like a normal functioning blood-brain barrier is some structural as well as osmotic gradients and biochemical processes that kind of create a barrier, I give the name, between the vasculature, whatever's in the vasculature and the brain. So if, for instance, if you have a toxin in your blood, it might access most of your body, but your brain would be protected from that. It would protect you from certain biochemical structures as well as larger molecules. But as the brain tumor, if someone has a brain tumor and as it begins to grow, it's sending out signals to really recruit more and more vessels to grow. And as those vessels are growing, they aren't forming properly, partially also because the tumor cells are getting in the way and a lot of those structural components. So the astrocytic foot processes are being replaced with these brain tumor cells. The tight junctions aren't able to form, and you see parasites aren't able to really get in place to help keep those vessels patent. So one of the reasons we're interested in looking at edema and in connection with molecular markers in particular is because a number of things show up bright on MRI. So as you saw in the previous images, edema is showing up bright. And as Andrea brought up yesterday, something else that shows up bright is inflammation or inflammation response to, say, for instance, immunotherapy. And so, and you can see here as the treatment is given at month -2, the brightness you see there is probably due to edema. Then even in month 0, but then as you go through month 7, 11, and 22, the brightness you see there might be due partially to edema, but also partially due to this inflammatory response. And so we want to begin to see if we can make connections between the model edema and its underlying cause. And so whether this brightness is associated with the blood-brain barrier breakdown or if it's associated with immunotherapy effectiveness. But first, we were really just wanting to answer the question of whether what we're seeing or whether what we're modeling is due to blood-brain barrier breakdown and make some connections between that and some RNA transcriptomic markers of blood-brain barrier. So I've heard a few people give their background here at the conference. And so mine is engineering. And so when I throw up equations on the board, I'm working with a lot of mathematicians. I just expect them to immediately know exactly what this is. But this is basically the block equations that explain the signal evolution for MRI, but I don't actually use these a whole lot. I usually use something much more simple. And so basically making certain simplifications. And so you can get this signal down to the S is the signal at a given time, and it's equal to the initial signal, which is related to which is oftentimes referred to as proton density because it's related to the number of water protons in any given voxel. And that's modulated by a decay rate constant known as T2. And that basically is, it's just characteristic of tissues. And so different tissues will have different T2s, and that shows up, you have a different brightness or darkness on the imaging based on whatever that decay rate constant is. And if you start to think about the tissue is not just a whole thing, but just the different compartments within the tissue, thinking about intracellular versus extracellular compartments, then you can think about this signal then being due to this weighted sort of sum of the signal that's coming from both the intracellular as well as the extracellular space. And just so to drive home the point of like what these images look like, you can see, for instance, cerebrospinal fluid. Your ventricles are mostly liquid, and they show up the brightest as more cells are introduced into that space. For instance, in edematous tumor, you'll get something that's slightly darker. And then where you have the most cells relative to extracellular space, you have something much darker, like normal appearing white matter. And so from this compartmental model of edema, so for instance, if we're able to get the signal at multiple times, so we call them echo times or TE, then we can calculate the proton density. We can make some assumptions from literature about what the T2 in the intracellular space as well as the extracellular space might be. And then we can basically fit what the fraction of intracellular space is, which is just going to be 1 minus whatever the extracellular space is. But what happens clinically is that we rarely get that many time points of imaging. We really just get one echo time. And so that means that we don't really know what the proton density is. So we have to begin to use some information we have about what the intracellular space or the extracellular space might be to figure out where in the space we might have a good S naught or a fraction intracellular space or fraction extracellular space. But we know some things already that I've told you, which is that we're expecting the normal extracellular space to be about 20% of the brain, and then FICS and FECS, we're expecting them to both be positive and to sum to 1. So from there, we can really constrain the space over which we're looking for parameters and begin to fit this equation. So Lee also did a great job introducing our image-guided biopsy study. So I can kind of skip through the slide a little bit. We did use 38 patients from that study who had 129 specimens. So about 40% of our patients were female, and close to half of our specimens came from female patients. So we calculated our model based on pre-surgical T2 weighted images. And of course, RNA-seq came after surgery from those samples. And for our correlations, we initially focused on 57 markers that were associated with the blood-brain barrier based off a review paper by Arvanitis. And we also looked at correlations based on categories such as self-reported sex, as well as the imaging phenotype of non-enhancing and contrast enhancing. And we did control for multiple comparisons. So we did see a number of correlations with this. In particular, across all the samples, as well as within the non-enhancing samples, we did see a correlation between what we call mean fraction extracellular space in regards with HIF-1 alpha abundance. And so HIF-1 alpha is interesting because it's expressed in hypoxic conditions. So as the tumors are growing rapidly, they're taking up a lot of oxygen, they're requiring more and more oxygen. And so you might expect these blood vessels to be growing under these conditions and to be recruited more under these conditions. As well, we saw significant correlations with SOX2, which is expressed, also seen expressed with tumor cells that have a proliferative or stem-like potential. Additionally, we saw correlations with PTCH1, which is a pathway that's associated with cell growth and proliferation. And we saw this for female patients in particular, or female samples, I should say, in particular, as well as in the non-enhancing regions. And then finally, further in the non-enhancing regions, we saw correlations with APOE and PIK3CA. APOE is associated with severe brain swelling, and as well, PIK3CA signaling is again associated with proliferation and survival of cells. So in summary, we were able to model edema abundance, and we found that it was associated with a number of molecular markers, particularly within the non-enhancing region for the blood-brain barrier. And we're hopeful that these significant correlations will be a first entree point to coming up with better clinical biomarkers for edema, tumor aggressiveness, as well as treatment. And some of our next steps include investigating gene signatures instead of just individual genes, as well as including more patients from our ongoing biopsy study. With that, I'd like to thank my lab, as well as all of our collaborators and sponsors. Thank you.
That was a great talk.
Thanks.
I may have missed this, but the specificity of your marker association with T2 signal in edema would, in my mind, require that you demonstrate that that's not what you see in the gadolinium enhancing components, right? You're comparing edema to solid tumor. In both cases, there may be some blood-brain barrier breakdown, but the non-enhancing region clearly doesn't have breakdown like the gadolinium enhancing does.
Yes.
So what's the correlate between those factors that are associated with blood-brain barrier function when you're looking at gadolinium enhancing versus gadolinium non-enhancing?
So I think one of the issues is that the gadolinium enhancing region is kind of like a region of almost like extremes, because you would have like the most the most factors would probably be in that region as well. You would have the most leaky vessels in that region, but you also have the most tumor growth in that region. And so I think the non-enhancing kind of represents more of like a crossover, and that's why you're seeing more of a correlation there, versus within the actual like core of the tumor, you either have a bunch of cells or you have like no cells because you have necrosis. So
if I'm understanding correctly, you've looked at the gadolinium enhancing component and compared it to the non-enhancing component with regard to that marker expression. Okay.
Yes.
I missed that. That's what I was asking.
So I didn't show them because they weren't significant. So I did do those correlations as well, but they did not come up as significant. So.
But the difference was significant between enhancing and non-enhancing, or no? So if you looked at SOX2 expression in the enhancing and non-enhancing region, did you see a difference?
I'm going to have to go back and look at let me see if I can find some things for you to look at, and I can discuss that more later.
Thank you.